being here. As I said before, Mike and I really weren't too sure if it would just be the two of us here and just chatting again. But it looks like there's actually quite a few people, and I know a lot of Canadians here. Also, I think there was someone who's going to join from Norway. Interested in what we were doing and what's going on. So really the structure of these sessions is that we wanted to really get the dialogue going to talk about the role of physiotherapists in the situation right now, so in an infectious disease pandemic, and really get a sense of kind of checking in what physiotherapists are doing around the country and kind of sharing resources, initiatives, and ideas so that we can all be stronger as a profession. So today's session is going to be a little bit different. Normally what we're going to do is we're going to plan it almost like a disaster response meeting where we'll go through the numbers, the situation report, initiatives and programs that are happening within the country and around the world, and share resources with each other. But for today, we're going to focus on really broad therapy, and then just a chance to see what everyone's up to and catching up. So I'll introduce himself.
Hey Phil, can you hear me?
Yep.
Yeah. Well, hi everybody. Hey, just before we kind of kick off, why don't we all just take a second and put ourselves on, everyone who's not talking, maybe just put yourselves on mute so that we can kind of go through this. And just like Phil said, thanks a lot for being here. What we're hoping to do is really initiate some solidarity among physios around Canada, but not just Canada. It's going to be around the world. So plenty of role for PT to begin. So before I even start my part, let me just give you a little background. I think some of you probably know. Phil and I need to do a little bit of intro here. So I've been involved in disasters for a couple of decades now, as you can see by the little gray hair on the beard there. So I'm really excited to be working with Phil on this one. And many of you on the call here also have plenty of experience. So we're definitely not the experts here, but we're only facilitating through this next very important phase for us. I'll mention it in a minute, but as you know, most of you will, the prediction models are showing a peak of hospital admissions somewhere in the neighborhood of April 2nd. So we're about to go into a real emergency mode here. And Phil and I have worked together overseas quite a bit. I'm not sure we've ever thought we would initiate it here in North America, but let me just say, so I am a physio myself. My research area really is in population and public health on the policy side. I'm at Duke University now, but I am Canadian. So I'm glad to be here, and we'll talk a little bit more about how we're going to structure these sessions into the future. So that's a little bit about me. I'll pass it back over to Phil now to introduce himself, and then we'll get right into the sit rep. Phil?
Sorry guys, this is Diana. I'm just going to jump in and say that Mike Landry is our Enid Green Memorial winner this year, top Canadian physio. Congratulations.
Oh, thanks. That's awfully nice of you to say, Diana. And I tell you, when we do that talk, I'll have plenty more material to be discussing. So I appreciate you saying that. But thanks. And by the way, what you've been doing over the years in cardio rest finally has really is going to strike a chord, and we'll talk about that. Absolutely, we will. And so thank you to you, Diana, for all your efforts over the last many years, in fact. But thanks.
Yes, yeah, thank you, Diana. And yeah, thanks everyone for being here. I see more and more people signing in, so it's incredible to see how many people are here, even though we just announced it yesterday. So just introduction. I know a lot of you here, but so my name's Phil. I'm a Canadian physiotherapist, but I'm also doing a doctorate of public health at the London School of Hygiene and Tropical Medicine in the UK. And basically, since I've been a physiotherapist, the focus of my work has been on first working in development and then working in humanitarian crises and disaster response. The work that I'm doing now at LSHTM, my research is really looking on how we improve access to health and humanitarian services in areas that are affected by disasters and humanitarian crises. And like Mike said, I really wasn't expecting to be working on this with him in Canada. But here we are. It's the situation we're presented with, so we're going to do the best we can to work and get physios and rehab involved. So I'm going to pass it back to Mike now, and he's going to cover. He's going to go through the sit rep, or the situation in terms of numbers globally and within Canada. And
what? Want the light on?
Thanks, Phil. Yeah. Lights on is good. Whoever said that. Hey, just make sure you got everyone's on mute, and then we'll kind of go through this. So. Yeah, so what Phil and I thought about is we would actually manage these meetings very similar to how we would in an emergency situation overseas. So wherever there are disasters, whether it's a natural or a conflict, as an example, usually the conglomeration of NGOs meet, and we do what's called the situation report. So that's what it's called, the sit rep. So that's what we're going to do every time we meet. And so I'm just going to read off some of the numbers, although in future sit reps we might look at different types of numbers. But for the moment, I just wanted to give you all, maybe this is good for our own reminder of the scope of what has happened. And so let me just start it just through the WHO, which is probably our best source. And I say the best source because they are likely bringing in information in very standardized fashions. If you want Canadian data, of course, let's go to the Public Health Agency, who, if I may say, has done a marvelous job in a very difficult circumstance. So I think we've got some good leadership at the top in Canada in terms of how we're moving. It's not perfect, but it's pretty good. So let me just read off a couple numbers. So what we've got here on a global scale as of today, March 22, is somewhere close to 300,000 global reported positive cases. We have about 12,000 deaths, reported deaths. And if we think a little bit more around Canada, we now have somewhere in the neighborhood of close to 90,000 people who have been tested. Just the denominator here is about 35 million people, but about 90,000 who've been tested. And of those 90,000, we have somewhere close to 1,200 or 1,176 who tested positive. These numbers are not going to be accurate in all cases, and it changes moment to moment. But these are data from the Public Health Agency as of today. BC, in particular, has the highest cases, both of reported COVID-19, but also deaths. So they're reporting somewhere in the neighborhood of 430 reported cases and sadly 10 deaths. Ontario is the second largest in terms of reported cases at 377, tragically with 3 deaths. Now, you'll know, of course, we all will know as health providers that these numbers will get large. And I need to always, and I'll probably be always doing the sit rep here, so I'll always remind us that when I say numbers of 10 or I say numbers of 3, those are 3 individuals with families, those are people. And so we get a little bit numb to the numbers, and I'll try always to make sure that we keep our bearings about us. These are 3 are still an important number to keep in mind. Just in terms of global comparisons, though, if I might, Italy, just yesterday, in fact, reported one of their highest number of deaths in one day, somewhere close to 700. And well, I'll read you the number. It's 793 deaths in one day. One day. They have a population of 60 million people. So if you think about comparing the U.S. the Italy with Canada, we're a factor of 2 here because our population somewhere in 35 million, theirs at 60 million. They've had about 60 million people test positive. So they have a significant number. Most of the news feeds, most of the prediction models are talking that the United Kingdom is 2 weeks delayed from the events that are happening right now in Italy. So Italy, from an epidemiologic perspective, has not seen a tilt down. They're still ramping up in terms of number of those testing positive, those presenting with symptoms, and then death rates. the UK is now presenting and preparing rather for a 2-week delay on that. And Phil and I have been in talks with our colleagues in the United Kingdom, Pete Skelton being the primary one, who is international global leader in this area, also a physio. And so we'll talk maybe of some of his voice a little later, and we will invite him to be part of this in future sessions. But just to give you that little bit of broad perspective, that's where we sit today. I'll tell you that here in the I do find myself in North Carolina at the moment. Here in North Carolina, we are expecting that tomorrow morning a shelter-in-place decree will be launched, meaning that severe restrictions on movement because of a real peak in the numbers that we're seeing. Anyway, I'll stop with the numbers because these are so large at some point they become a little numb to it, but I think we're providing a little scope of where we are today. And this is important because the numbers are going to be, the absolute numbers are going to be important, but the trends over time are what we're looking for as we move forward. We'll speak a little bit in a moment around, despite these numbers, the role of the physical therapist, the physiotherapist is significant, although not always recognized. So let me just end with this initial sort of review of the numbers, saying that these are unprecedented numbers. I know this is a word that's being used liberally, but these are very interesting and difficult times. Just in Nova Scotia today, I think you may have seen this, declared that their borders are now closed to all traffic other than necessary mobility because of their fear around. These are techniques that work. There is undoubtedly social isolation and physical isolation works. When you close borders in cases like this, it will work. So our job right now as physios is to say, let's take directive. Let's be the change we want to see. So let's model these behaviors into the future. But then all of a sudden start thinking, what role can we actually play in minimizing planking? I actually don't like, I think Teresa Tam came out, was it yesterday, rather than talking about, flattening the curve, she wants to plank the curve. I think I prefer that nomenclature to it. So that's a little bit of a global overview. I'm going to pass it back to Phil. And just another reminder, whoever, if you can put just a reminder to put pause. We've got a good visual of somebody making something on the stove there. So maybe just hit a pause so that we're clear. Okay, go, Phil.
Thanks, Mike. So, yeah, as Mike was saying, so the numbers are unprecedented, and we're likely to see within Canada and North America a spike in cases over the coming weeks. And really, physiotherapists and rehab professionals have a really important role to play in all parts of this disaster. So right now we're still in the preparedness stage, although we're about to get more into the response phase. So when we look at the preparedness phase, really what physiotherapists can do here is we need to get patients out of hospitals. And really what we're doing there is we're reducing the risk for people. So there'll be less people that are exposed to COVID-19 within hospitals. So we need to get them out as quickly as we can in the preparedness phase. And that's what all physiotherapists in Canada can do, MSK physiotherapists. And the other thing that we can do in the preparedness phase is really get our cardiorespiratory physiotherapists and rehab professionals in ICUs to, again, get people out of those acute care centers and off of mechanical ventilators if possible. Because we are going to see pretty soon that there's going to be a huge demand for all of those acute care resources within Canada. In the response phase, it's a lot of the same. So physiotherapists can, again, work on just getting everyone out of the hospital so that we can then free up all of our medical professionals, our doctors and nurses and respiratory therapists so that they can focus on working with people that have contracted the virus and are then in need of acute care and cardiorespiratory techniques and these mechanical ventilators. And so some of the ways that we can do that is to have physiotherapists relieve rehab workers within the hospitals who are skilled in actually working in acute care. so that then they're able to go and do that. We can actually get physiotherapists in hospitals to provide care to patients. We can even, there's been some discussion about having physiotherapists work in emergency departments to assess and diagnose and treat conditions that fall within our scope, therefore relieving the resources that would be in those departments typically. And then when we're working in these acute settings, the research has shown that cardiorespiratory physiotherapy can reduce sometimes in some cases, reduce the need for mechanical ventilation and reduce the duration. So by doing that, what we're doing is we're reducing the demand and we're creating faster turnaround times for the influx of patients that are coming in. Now, there are, of course, a number of different ways that physiotherapists can support in these areas, and there's going to be also effects in the long term and in the response phase. And I'll pass that off to Mike to go through. Mike, I think you're muted still.
Thank you. Yeah. I was just giving a hard time to my other colleague for doing exactly what I just did. So there you go. So thanks, Phil. Yeah, there's obviously a bolus that is going to require the PT to be involved in that acute setting. I'll just give you a little example. Both Phil and I did this in Nepal after the earthquake, where Phil went in to actually train nurses around a criterion-based 3-point or 5-point system to say, okay, when a patient hits this level of function, they can be discharged to a different level of care, which would increase the throughput for patients. So I think we can provide really that optimization perspective in an acute care setting. Now, if we start elongating this trajectory, in 4 months from now, we're going to have a global cohort of people who may or may not have really moved very much. And it might be okay if you're relatively healthy, probably like most of us on this call. But if you start thinking about people who already have pre-existing conditions, who are at high risk for stroke, the level of stress that we're experiencing now and the level of inactivity and lack of access really becomes an issue. And this becomes important from our perspective in terms of, managing the outcomes of COVID-19 downstream. Now, I'm quite sure all of you will appreciate the best time to really begin thinking about the downstream is now. So although we're saying, one, there is a role in that acute setting, right away, we need to be starting to think about how this is going to play out in the long term for patients who may be compromised in many different ways, may be the so-called vulnerable group, and if I might just say, other people, persons with disabilities who are already in an isolated environment, and now we're isolating them even more. This will become really important for PTs and OTs to work as a real, in our opinion, a real interdisciplinary team to start considering how that's going to work downstream. I'll just put a point there. Now, think about us as physios. If many of us are going to be located and not really working as we did before, and of course, tragically, I'm sure many of you on the call work in private practices, and the volumes are clearly different now. And maybe you won't have those volumes again for a few months, mercifully, but there's a time here. So we have to keep up our own competencies so that we're ready to react and to be part of the next phase. So this is happening on a couple different levels. We had and I think Phil will share some really important examples later, but there is an example of a clinic owner there in Canada, just outside of Ottawa, who's maintained their clinic at an emergency level only. So when patients are experiencing really acute musculoskeletal conditions, they're open to see that cohort of population. They've implemented the right amount of screening, the right amount of PPE, et cetera, such that decompresses volumes that could potentially go into hospitals. So clearly there are many different angles, some of where the PT can practice and be useful in these kinds of scenarios. Some of them are as Phil described, but there are many more that go down the stream. And so this becomes important for us to not think about that. And I think we might all agree here, the best time to plan for a disaster is not while the disaster is happening. And so we are all kind of, well, Phil and I and others, we're reaching out, for instance, to the Canadian Physiotherapy Association, the American Physiotherapy Association, the Australians. And we have some plans where we'll probably release those plans this week around, how PTs, how physios can be involved now and get ready for that future bolus as we move through over time. Hopefully this goes fairly quickly, and if we all act in solidarity to enact these public health measures, I think we probably could do that. So I'll stop there saying the bottom line is that we have a continuum, just like we have in any other patient population. Up to now, most of what PTs have been focused on are non-communicable diseases. This is a reminder that we have a role to play in this kind of infectious disease outbreak. And this is exactly what Phil and I are trying to promote through these discussion sessions and through a variety of other things. So I'll stop right there and I'll pass it back to Phil, who I think is going to give us a few examples of models that seem to be being implemented today around where PT can work and be effective and optimize the system. And then after that, I think we'll open it up for some discussion and debate. Phil?
Thanks, Mike. Yeah, so I'm going to mute someone there. So yeah, so there are implications that span all parts of the disaster continuum, as we would say, and even within towards the long-term recovery. And another point that was kind of brought up in terms of the long-term aspect of it is that we have all of these physiotherapists and clinics that are now closed, and potentially physiotherapists who won't be working for a long time. So if we can get physiotherapists in hospitals providing care in acute care settings and doing our part, not only are we showcasing our ability to support in these situations and our role as acute care providers, but we're also keeping up our skills and really showcasing the value of physiotherapy in all types of disaster situations and humanitarian crises. So one of the things we want to do in these sessions is really share the initiatives that are happening around the country. And one of the things that came up this morning, that whenever I was posting about this session, someone from Halifax sent me a message and said that what they're actually doing is they have physiotherapists that are working in COVID-19 assessment clinics. And they have physiotherapists that are working and assessing patients and doing some of the work and offloading some of the work on doctors and nurses in those situations. So that is one example of how physiotherapists, because we are trained in infection control practices, we can have a huge role in this preparedness phase and up into the disaster response, where it's not only just working with patients and doing the things that we would typically think a physiotherapist would do. Now, the other one that's kind of coming down the pipeline, and we'll try to get people in the next sessions, that there are some clinic owners that are working with local hospitals in terms of trying to get exactly what we just talked about in hospitals around the country. So clinic owners working with connections within hospitals to get physiotherapists in and get patients out, and then also providing that assessment and treatment in emergency rooms. So those are the kind of the two. I know we need some positive stories right now, so those are two good initiatives that are happening within Canada. And now we'll kind of open it up to everyone. We'll try to get a good discussion going. If you have any questions about what's happening, or if you have any initiatives that you'd like to share. I know if Jen O'Neill is in as well, she might have a little bit to talk about tele rehab, but we'll open it up. Anyone have any initiatives or questions?
Hi, Chastity from Miramichi. I'm just wondering, when it comes to, I guess, ARDS or, any of the side effects here of the COVID-19, are the problems of chest physiotherapy any different? Like, are we dealing with secretion retention issues? Is prone for ventilation things that are happening that seem to be effective. I just wonder if someone could speak on that.
Hi, this is Diana. Great question. My understanding is that many of the signs of people on ventilators are just that, very much like pneumonia with superimposed ARDS, and that anything we would do for that, we would do for these folks. Does that help answer the question?
Yes. Is there any scarring or fibrosis that's associated with this that would be different from other things?
I don't know about anybody else, but so far I have not been able to find anything where they've talked about the pathology of COVID-19 past really the acute signs and symptoms, as opposed to the anatomy or pathophysiology of it after the fact. I mean, we really haven't had after the fact yet. My guess is there has to be some scarring.
Yeah, let me thank you, Diana. I'll hop in on this one. I actually was preparing for that very question. One of our colleagues, her name is Lauren Geddes, and she works at the Royal Free Hospital. She's a physiotherapist specialist, works at the Royal Free Hospital in London. And a few years ago, in 2014, she was one of the first physios to gown and go in and treat patients with Ebola. And that was 2013-14. And so since that time, she has been deployed inside of the Royal Free, which is a huge hospital in the NHS. And this is exactly her question as well. We just don't know yet if COVID will be anything different from SARS or any other, as Diana said, pathophysiological outcomes here. But in this case, probably in a disaster, or this like preparing for deployment and for response here, we may just make a good assumption here that there will be damage. In cases like this, earlier treatment leads to better outcomes. And so although we don't know from an emergency response perspective, we should assume that it will. Let me just make one last point, and then we'll see if anyone else has a question. One of the things that Phil and I endeavor to do in these sessions, and we're sort of calling it Cross-Canada Checkup, but I think it's a little bit broader than that. We will take that in note, and we will do our best to answer that question. So I just sent a message on the chat here that this very session will be posted on a website that we're launching. It's www.ptcovid19.org. It's not fully running. Hopefully it'll be tomorrow. And so we will put this recording, and we will put some of the questions, and we will endeavor to search the literature to make sure that we've answered it to the best of our possible abilities. As Diana says, we're early in this phase. We don't know what the long-term outcomes are going to be just yet, but we do want to make sure that we're maintaining a high level of quality and being driven by evidence. So I'll stop there and pass it over to Phil. But thank you for that question.
Yeah, thanks, Mike. And just to touch on that a little bit, so it looks like there are going to be kind of international guidelines that are going to be released, and that should be early this week is what I hear, and it should talk a little bit more about the research that is available and what we do know about COVID-19 and specific treatment in terms of rehabilitation. So we'll try to share that if that comes out tomorrow. If not, we'll share it with
Phil, can I jump in?
Yeah, absolutely.
Like I haven't already. This is Diana, everyone. My understanding is, I don't know how many of you know, but Canada is a member of the International Confederation of Cardiorespiratory Physiotherapists. So that's WCPT's cardio-resp arm, just like we have a cardiorespiratory division for the CPA. And so there are Canadian physios who are members on the executive. I've just come off the executive, and Dina Brooks from McMaster. These folks are working with people right across the country on these things that Phil and Mike are talking about coming out internationally. Also, if anybody knows Physiopedia at all, Physiopedia came out with some materials, I think it was just yesterday. And although you need a membership to Physiopedia, which is a great platform for physios, they're letting this stuff go out free. And so you can take a look at that. The only difference there is the UK has different terminology from some of the things that we do or say, like they don't do PPE, they call N95 masks something else. But those are two good resources, one that's coming out internationally and then Physiopedia out of the UK.
Thanks, Diana.
Hey,
Yeah, we'll
yeah,
try.
that's
We'll share some resources as well. We'll kind of do a one-page summary of everything, and we'll include the Physiopedia in that as well.
Yeah.
Back to you.
Yeah, hey Phil, let me jump in for a sec. Excellent points, Diana. And listen, we're all working on this together. So if anyone out there hears of or knows of new information, please let us know. And we will share our emails, we'll share everything on that website. And we will link directly to Physiopedia, and there's some other resources that are happening. There's, in fact, Archives of PhysMed Rehab just put out an editorial. Turns out Phil and I did as well, and so we're going to post as much of that information as we possibly can. But if we've missed something, please let us know. And even more so, if you have some good stories of where PTs have been very involved. And let me go back to Lauren Geddes. We're going to have her on this particular platform, talking a little bit about her experience around treating people with infectious disease and how that may or may not be different to what we're seeing now. So anyway, my plea right now is if you find something, please let Phil and I know, and we'll make sure to post it. Phil?
Yeah, nothing more on that, but I'll open it up for more discussion, questions.
This is Jenny Day from North Vancouver. I have a question for Phil and Mike about, hi, just about implementing some of those things you were talking about, like getting into the hospitals to relieve some rehab workers, or getting into the emergency departments to kind of practice within our scope. Is this something that we should be doing like hospital by hospital basis? Are we waiting for calls from our public health authority? Are we waiting for the CPA to kind of advocate for us? Like, I know personally I have just applied for a couple of positions because they were posted already, but what's the best way collectively to go about doing this?
Yeah, great. Oh, Mike, you want to go ahead? Were you gonna say?
Yeah, let me give a little bit, and then Phil, maybe you take it after this. So Jenny, yeah, good to see you. It's been a long time. So here's the reality is Phil and I have worked and we've reached out to the Canadians, Americans, Australians. Let me just tell you a little bit of what we're doing in the United States. So we are working with APTA. We're reaching out to all of their members, and those members, and this is very preliminary, right? So the idea is not fully vetted yet, but close. We're going to reach out to the members. The members will volunteer. They will lean in, you know, as they say. So lean in and volunteer, self-select. If they go on this roster, we will then, through the association and other means, seek to link them with an area of demand. You see, so it's a real supply-demand issue. Again, we do this in disaster response all the time. So the other point in that, so the point is, you know, demand and the supply. How do you link them together with people, for instance, like you, Jenny? The intervening variable here is, though, also Phil and I are going to be with others creating a boot camp like education platform, which will, you know, bring everybody who's on this roster up to a certain level so that we can inform the demand side of where the training is. Also, we'll populate it as we go along. And many of you on this call might have things, education online platforms that you could let us know about so that people can self-select. In other words, if we find a place for them to be employed or to work, rather to volunteer, to contribute in a long-term care facility, well, maybe there are greater specific points that they need to train up to if, for instance, they've not done that in a while. So we're actually trying to make that link, and we're also trying to create an environment where they can learn a little bit more and create an educational platform so that they can be more prepared for that. You know, in a disaster, sometimes please take this in the way the spirit of it is, but in a disaster environment, sometimes if you wait around for perfection, you've waited too long. So we would love if we could have had this conversation 5 years ago and prepared up all of us to get ready for this kind of event, but we didn't. We need to do that in the future, and we're quite certain that's going to happen. But for today, what I think is important is that we're going to be reaching out throughout America, the United States and Australia, and working with those associations. We're in similar discussions, by the way, with the CPA, and there's things that we're going to work through, and you'll hear about it this week. Phil has an excellent example, though, in the Ottawa Valley that might make sense here.
Yeah, just to to touch on that too, is that we're working with associations to try and make that link. There are certain things to figure out in say in the US and Canada and that in terms of regulation and working with colleges and bodies and that, but definitely keep an eye out this week and we will keep you updated on all of that. And yeah, one of the examples, so within the Ottawa Valley here that's potentially going to start within a clinic is a clinic owner who's taken the initiative to really make the connection and use kind of his resources to get this type of initiative going. So because clinics are closing all over the country, there is a potential for private practices to reach out and really make those connections with the acute care hospitals and those centers. But in terms of, I know the question was like, what do I do right now? I think I'm going to try to answer it rather than just being vague. I think one of the thing that you're doing, like applying for those acute care positions within hospitals is really good for the time being. Because really, if you can get into hospitals and provide that service, even if you're an ortho or MSK physio, but you're freeing up someone else within that hospital who knows about acute care and cardiovascular, that's huge. And then in terms of, being part of, say, a database and going through this boot camp that Mike was talking about and linking with hospitals, I know it's hard, but kind of just stay put for now. We're going to have more information for you in a couple of days.
Can I jump in for a second? This is
Yeah,
Jen.
for sure.
Just on that note, I know some of us working in research institute that are linked with hospitals have been asked to be redeployed. So we're actually, I think if some of the physios out there are also doing research and aren't necessarily practicing, they might want to ask their hospital or the research institute if they could be on the redeployment list. So the hospital actually creates a